Good evening, everyone. Welcome to UT Southwestern's Science Café. For our regulars, welcome back. And for our new guests, we are so pleased to meet you this evening. My name is Charlonda Thompson, and I'm a part of the Public Affairs team at UT Southwestern. And on behalf of my colleagues, Joya Lang and Jenny King, our guest speaker, Dr. Asal Rahimi, thank you for joining us tonight. Science Cafés are online conversations where our speakers take you on deep dives into science topics. We also have a little fun while we're learning, and our format is casual and interactive. And we encourage you to ask questions and engage with us during the program. This evening, we will be discussing breast health, breast cancer treatments, and the latest radiation oncology research with Dr. Asal Rahimi. More on her in just a moment. Before we begin, we would like to mention a few technical matters. We are recording tonight's program and live streaming it on our UT Southwestern's Twitter page. Please mute your microphones to help everyone's audio clarity. Please unmute if you are called on to ask a question. We encourage you to utilize the chat feature to list questions for Dr. Rahimi. We will start a Q&A at the conclusion of her presentation. Joya will be facilitating our Q&A, and we are monitoring your questions in the chat box. Finally, just a reminder, while we cannot answer personal medical questions, we would love to hear from you with general questions. Now I am pleased to share a special video message from our partners at the Dallas Mavericks and player Dwight Powell.
Good evening, UT Southwestern Science Cafe. I'm Dwight Powell, the Dallas Mavericks, and I'm so glad you took the time to learn about the very important topic of breast cancer awareness. This topic hits home for me and led me to establish the Dwight Powell Children and Family Support Fund at UT Southwestern. I have a game tonight, but I wish I could listen in this evening to hear Dr. Rahimi share her work in radiation oncology. I know it would be a wonderful, impactful discussion. Go Mavs.
My name is Dwight Powell, and I'm a center power forward for the Dallas Mavericks. The Dwight Powell Children and Family Support Fund here at UT Southwestern is a fund specifically designed to help families maintain a level of normalcy while going through cancer treatments. My mother passed of cancer while I was in university. Fortunately, I had some people around me that were able to support me, but as I've gotten older and realized that there's a lot of kids younger than even I was that find themselves in a situation where their parent is sick, they may not necessarily have that infrastructure to support them. We want to find ways to help support the family, to take the burden off of them and making sure that they can maintain the normal course of their life as they go through this hard time. I know it's tough, and I know sometimes it's hard to reach out for help. So I hope that whether it's a family in need or whether it's a family that knows a family in need to direct them to this, because there's plenty of opportunities that you can come in and seek help, whether that's financially or whether it's just learning how to talk to your child and how to explain to them what's going on, because it's not necessarily the easiest thing to talk about. We have a great partnership with a great hospital in UT Southwestern, and we've started some great work, but it's not just about starting, it's about seeing it through. I think if my mom was able to say something to me right now, she would say, keep going. One of the most important things you can do in your life is if you go through something tough and not just get through it, but help other people get through it. So that's the dream, is to help these kids live a normal life and help these families heal and help these parents get better without that burden.
All right, go Mavs. And with that, I'm pleased to introduce our guest speaker. Dr. Asal Rahimi is a highly trained and board-certified radiation oncologist. Dr. Rahimi is an associate professor in the Department of Radiation Oncology at UT Southwestern's Harold C. Simmons Comprehensive Cancer Center and Chief of Breast Radiation Oncology Service. Joya is posting the bio link for Dr. Rahimi into the chat. Please click through to read all about her incredible work. In addition, there's a brief video about Dr. Rahimi and her work in radiation oncology here at UT Southwestern.
At UT Southwestern, we specialize in delivering cutting-edge treatments and radiation for breast cancer. Patients are going to be getting multidisciplinary treatment with world-renowned research. We specialize in stereotactic partial breast irradiation. We are minimizing the number of treatments, and we're also minimizing the amount of tissue that is being irradiated, such as the lungs and the heart. We have a cardiac sparing program to further reduce any potential side effects to the heart. We have 2 machines that we can offer these treatments on. The Cyberknife that can track the patient's breathing during treatment to help us minimize the amount of tissue that we're irradiating. The other machine is called the Gammapod. We are the second institution to have a Gammapod in the world. We are able to immobilize the breast to try to minimize the amount of tissue that we're irradiating. We're one of the first institutions to offer extremely short courses of radiation, what we call hypofractionation. One of the main benefits is the convenience for the patient so that people can get back to their normal activity on a daily basis. We are also involved with translational research that may further improve the outcomes of our patients. We want people to come here and feel that they matter and that their team members are caring for them so that they can get through these really difficult times in their life. That's what keeps all of us doing what we're doing, and we hope to offer that type of care to every person that comes here.
Dr. Rahimi, thank you for joining us this evening. Welcome to Science Café. The virtual podium is yours.
Thank you. Thank you so much for having me. And I was excited to hear about the Dwight Powell Foundation, which seems to be serving a great population and very important. So can everybody see my screen? I just want to make sure. Okay, great. Okay, well, first off, here are a couple of my disclosures. And I wanted to start this off by meeting my audience. I wanted everybody to kind of introduce themselves. So with that, we're going to just start off with a poll. And I wanted to know which best describes you, A, B, C, or D. And we have several different options there. So I see the poll going here. And it looks like about 70% of the population are people that just want to learn more about breast cancer, which is great. Okay, so we'll go ahead and end the poll. Okay. And next question is, do you know anyone close to you that has been affected by breast cancer? And just very quickly, it's 96% of people know somebody that was affected by breast cancer. So breast cancer affects 1 of 8 women in their lifetime. So this is something that is real. It's something that affects all of us, whether it affects ourselves or someone we know or love or care about. So this is an important topic. So the COVID pandemic has led to a decline in cancer screening. So this is super alarming. This is really something that we need to bring a lot of awareness to, because with the pandemic, I think there has been a lot of issues and circumstances where people haven't gotten the medical care that they should get. And the reason that this is so important as far as breast cancer screening is because mammography has helped reduce breast cancer deaths by over 1/3 since 1990. So that is an astounding number. Because of mammography, many breast cancers are diagnosed at a really early stage, which means that they're highly curable and highly treatable. So if people are not getting these mammograms, we have a problem. So what is an average risk woman screening guidelines? So per the American Cancer Society, at the age of 40, women should start having the opportunity to begin screening if they choose. I personally feel that women should start screening at age 40. However, per American Cancer Society, they have the option to start screening. By age 45, every woman should be getting yearly mammograms. And then by age 55, there is this option per the American Cancer Society to transition to mammograms every other year at age 55, or you can still continue the annual mammograms depending on your preference. Again, I kind of urge everyone to continue these as long as they're healthy. So once women are older than age 55, they can continue to have regular mammograms as long as they're in good health. So mammograms really do a great service for women and really do help pick up a lot of breast cancer. So I think starting at age 40 and continuing annually until as long as you're in good health is a great strategy. So the challenge I'm going to ask everybody that is on here is, I want everyone to ask either a sister, a mother, an aunt, daughter, or a very dear friend if they are up to date on their mammograms. And that's what we'll do for Breast Cancer Awareness Month. And if we do one thing from this talk, I want you to do that. So let me kind of start shifting into talking about some breast radiation and what we do for like early stage breast cancer patients and kind of what we're doing in the breast radiation world. So typically and kind of standardly, what we've done for early stage breast cancer is treat patients with whole breast radiation. And so basically what that means is we treat the kind of like a square over the breast, and the radiation has typically been for about 6.5 weeks, daily treatment, so 33 treatments. There are shorter courses now that are about 4 weeks, but still daily treatments coming in. And what you can see on the inside of the body, so this is a CT scan, and the beams kind of come in tangentially, so they kind of come in at an angle. And when it does that, it can get close to the heart. You'll radiate some of the lungs, but this is what we've been doing for over 50, 60 years. We do have some advances, and we're going to talk about those. So one of the major advances that has occurred over the last, I would say, 2 to 3 decades is something called partial breast irradiation. And we started doing this in the late 90s. And when we first started doing this, a lot of people were doing a technique called interstitial brachytherapy, in which they put these catheters into the breast. And then basically those patients would be treated twice a day over 5 days, so 10 treatments. And then they improved that, and then they did something called intracavitary brachytherapy, where they can put like kind of a balloon or a device inside the breast and then hook it up to a radiation machine. And again, they would get the 10 treatments over 5 days. Some other advances have been intraoperative radiation, where you could do the radiation at the time of surgery. There's some advantages and disadvantages to that approach. Many institutions don't have intraoperative radiation available. That's probably the biggest downfall of that. And then the most common way of doing it is something called 3D conformal, which is basic radiation therapy, which is basically just on a regular linear accelerator that most radiation oncology institutions would have. But when we do that, we end up treating a lot more breast cancer, because the techniques of 3D conformal, they kind of treat in like a wide area that they're targeting. So it's not very precise. So it ends up treating a lot more tissue than what we would want. So one of the techniques that we have pioneered here at UT Southwestern over the last decade is something called stereotactic partial breast radiation, which we have been doing since 2010. And we have done probably one of the first largest clinical trials utilizing this technique, and have been continuing to optimize this treatment over the last decade. So here is a close-up picture of interstitial brachytherapy that we talked about, and then the intracavitary brachytherapy. So in order for something to be to change to a standard of care, it requires a phase 3 clinical trial. And so there were two major studies. That one occurred in Canada called the RAPID trial. The other one was in the United States called the NSABP 39. But basically what it was a phase 3 clinical trial where they randomized women to basically whole breast radiation versus partial breast radiation. And what they were looking at was they were trying to see, are these the same as far as local recurrence and survival? And can we start treating early stage breast cancer patients with partial breast radiation? And most of the techniques that were used in this was either a 3D conformal technique or in the NSABP 39, not this trial, but the other one, they were also using intracavitary techniques. But in this trial, they used pretty much mostly 90% were the 3D conformal technique. And then what they did was they had their nurses do cosmesis ratings on the way that the breast looked after certain time points. And they used a 4-point scale that is very common in breast cancer literature. And it's based on the way that they grade it is excellent, good, fair, or poor. And under each one of those categories, we're looking at different things like the shape of the breast. Has it shrunk? What's the texture of the skin? Is it darker? Different things that radiation potentially could do. And so that's how we come up with the 4-point scale. So, but what was interesting in this study was that using a 3D conformal technique, at 7 years, the nurses noted that in the whole breast radiation, 19% of the patients had fair or poor cosmetic outcomes versus 36%, so almost twice as much of the partial breast had fair or poor outcomes. So this was kind of alarming and surprising, because you would think that if you're treating a smaller area that you would have better outcomes. But again, the technique was a 3D conformal technique. So the margins were very large, and the margins were much bigger than what we would normally do. And we're doing higher doses. So that's why we think that we got these outcomes. So definition of 3D conformal is basically when we are using just several different beams to kind of make a shape, to conform to a shape. And then SBRT, or otherwise known as SABR, we're delivering high doses of radiation, and they're typically 5 or fewer treatments or fractions of radiation. And we basically are using special devices so that patients don't move up. So they have really nice setups, and we can have kind of these like sub-millimeter radiation targets. And that's really the big difference between SBRT and 3D conformal, is we're using very sophisticated technology to further pinpoint the tumor and just treat a lot less tissue, and we're doing it in 5 or less treatments. So just to kind of show you what that would look like in a patient. So this is a prostate cancer patient. And in this technique, we're using 4 fields, and the prostate is here, but you can see that the dose is kind of going all over the pelvis here. Whereas with the SBRT technique or SABR technique, the dose is kind of really wrapping around the target that we want, and we're not getting a lot of high dose in other parts of the pelvis. So it becomes much more precise. So let's talk about stereotactic partial breast irradiation, which is a fairly new technique in the last 10 to 11 years. So the platform that we first started our program on was the Cyberknife, which is basically a very highly specialized machine that has robotic capabilities. So when the patients are laying down on what we call this couch right here, it can move in all different directions. And then this machine over here, the head of the machine, can also move in a lot of different directions. So our first clinical trial, we wanted to do 5 treatments because everybody at that point was doing 10 treatments of radiation. We wanted to make it even more convenient and just have it be once a day rather than twice a day, which the other regimens. And we did a dose escalation because at that time point, we didn't really know what was the optimal dose for a 5 treatment regimen. So we were trying to figure this all out and see what the human body could tolerate. So we had 5 different dose cohorts, and we increased the dose in each one of those dose cohorts. And of course, we looked at local control, and we had really good outcomes, really high local control. But we also looked at cosmetic outcomes. And we had a physician assessment, and a patient assessment, and a panel assessment, which comprised of 7 physicians and 1 patient navigator, which was basically a non-medical volunteer. And the 7 physicians incorporated some breast radiologists, breast surgical oncologists, breast medical oncologists, and breast radiation oncologists. So very highly specialized breast cancer specialists. And what we found was at 36 months, over 90% and all the way up to 98% in these 3 different groups all said patients had excellent or good cosmesis. So this was much more of an improvement compared to what we saw with the 3D conformal techniques and the rapid trial, which was very, very good news for us. So this is our manuscript in which we detail these cosmetic outcomes in much more detail. And here are the patient-reported outcomes. And when you look at the dark gray, basically these are the 5 different groups, the 5 different doses, and the dark gray are who had the number of patients that had excellent or good cosmetic outcomes. And you can see there's very little light gray, which is the fair or poor. So then the same depiction here when we're looking at physician-reported cosmesis, you see more of the dark gray. And then for the independent physician panel, you see also the same thing, more of the dark gray, so the excellent good cosmesis. So these were great outcomes, and the local control was very high, and the survival was extremely high also in this trial. The other thing we learned was that some women, 11 women, developed something called fat necrosis, which is kind of like a deep scar tissue in the breast. But what we found was that was really associated with treatment volume. So it's really important that when we work with our surgeons, they all know that we like to have kind of like as small of a volume as possible for the lumpectomy cavity. Of course, having an oncologic surgery that removes the tumor is number one, but there are ways that surgeons can manipulate the cavity to make these cavities smaller, so that as a radiation oncologist, we can pinpoint a smaller cavity and really reduce the risk of fat necrosis. We also came up with different dose constraints that are published in a separate manuscript to kind of help guide other physicians that are using these techniques to reduce the risk of fat necrosis, which is very important. It's something that we now implement in all of our 5-fraction stereotactic partial breast irradiation plans. So that was one of our very first trials. Our second rendition of our trial was, well, we said, great, we've been very successful with the 5-fraction regimen. Now let's try to mimic an intraoperative breast radiation technique and try to do it in 1 fraction. Let's do it in 1 fraction. That's a lot more convenient than 5 fractions for patients. So let's do that on the Cyberknife. So the intraoperative radiation that I talked about is being offered in some hospitals, but a lot of hospitals don't have that technology. And one of the downfalls of the intraoperative radiation is that you don't actually have the final pathology when they do the intraoperative radiation, because they usually do it at the same time as the surgery. But if we did it with a stereotactic technique, we would have the final pathology while still maintaining the convenience to the patients. And then we would also have imaging, like we would know where the heart is and the skin is, which is a little bit harder to do with the intraoperative radiation. So in this clinical trial, we started at a little bit of a higher dose than what they did in the intraoperative radiation trial that was called Target, because we weren't doing this radiation right at the time of surgery, and we have to account for biological factors like vessel changes, and sometimes that area doesn't completely get oxygenated as it normally would if the area didn't have surgery. So there's usually more scar tissue. So we wanted the radiation to overcome some of those issues that you don't have during intraoperative radiation. So we elevated our doses, and we had 3 dose cohorts, higher than the doses that were done in the Target trial, to try to see again what was the maximum tolerated dose that a patient could have, and to try to really kind of see what is going to be the optimal dose if we were going to do this in a one and done type treatment. So we have presented this data in abstract form across the world, including in Italy. The actual manuscript for this will be, we will be presenting this in Chicago at Astro on Monday, and the actual manuscript will be available online on Monday as well. But this is the data from last year that was presented. And we were able to present the first 2 cohorts with follow-up of 27.3 months and 15 months. And at that point, the maximum tolerated dose was not reached, and we had pretty low toxicity, and the cosmetic outcomes for MD and patient were over 90%. But we will have this in full manuscript form with longer follow-up next week. So this was the first patient we treated using the Cyberknife. She had a rather small breast, as you can see here, so it looks like we're treating a much larger area, but when you actually look at how big the volume we were treating, it was only 27 cc's. In the first trial that we did, most of the treatments were close to about 100 cc. So you could see that this was a lot smaller than what we normally have. In this particular patient, our surgeons here at UT Southwestern worked with us, and we put a device inside of the lumpectomy cavity to make it smaller, and it worked out really nicely here. So that was kind of like the first couple of years of like our Stereotactic program. And over the years, it has kind of evolved, and we've been very excited to incorporate a new piece of technology called the Gammapod. And this is a machine that specifically delivers stereotactic partial breast only for breast cancer patients. It was developed at University of Maryland, and UT Southwestern is the second site to have it in the world. And we've been treating on this for since December of 2019. So we have a lot of experience treating on this machine now, which has been actually a very, very, very useful machine for us. So this treats with live cobalt radiation sources that are housed over here. There's a breast cup that I'm going to show you in the next slide, but patients come on in the vertical position, and then this machine puts them on into the horizontal position. And then these doors open up, and these cobalt sources actually rotate around the breast and deliver like a very highly specialized, highly conformal, and what I mean by that, the dose kind of wraps around the area we want it to without spilling to other parts of the body, like the heart and the lungs. So it's a very highly sophisticated machine that gives us the tools to be able to do that. So basically, I kind of just went over this. This is what the breast cup looks like. So the patients put the breast in, we fit them for the right size, and then it's hooked up to some tubing, and that tubing is actually a vacuum. The vacuum is similar to what you would, a woman would feel, or around the same pressure as like a breast, like a milking for breastfeeding, the pumps for breastfeeding. So it's very similar to that. And this is what it actually looks like on the patient's breast. And then once we get this breast cup fitted, then they would go onto that vertical machine that I was showing you, and then we would load them onto that to go into the horizontal position for treatment. So the cobalt sources, there's 25 of them, and they basically will all kind of pinpoint the area that we plan, and it is able to give us just a really beautiful plan. So what is the whole process? So for one treatment on the Gammapod, it takes about 2 hours plus or minus 30 minutes. So it's about a 15 to 30 minute cup placement. Then a CT scan, which is where we do our radiation planning, is another 15 to 30 minutes. Then we do treatment planning. So we do like real live treatment planning every day that we treat on the Gammapod. So it's like highly personalized every single day. And then the treatment itself is anywhere from 15 to 25 minutes. And then the cup removal is about 5 minutes. So that's basically how we get to the 2 hours per day per treatment. So here's kind of really where the meat of this is. Here is a 3D conformal plan. So you can see this is our cavity. And then you have to have these really large margins to account for just being on a regular linear accelerator. And then you get dose spillage kind of all into some of these other organs. So this is the heart is over here, but if it was on the left side, there would be some more dose into the heart and things like this if you were using a 3D conformal plan versus on the Gammapod using a stereotactic partial breast plan. You can see our doses are much tighter, and we're getting a lot less dose to a lot of other breast tissue and ribs and liver and just the surrounding organs. So we have formed a consortium. So I co-chair the Gammapod consortium with the University of Maryland. And we are now unloading different sites across the world, including Allegheny and Pittsburgh, which they should be going live soon with this machine, Ottawa Hospital in Canada, And then Udine, the University of Udine is going to be on-siting here in the next several months as well. And then Shandong Cancer Hospital in China. And then we will have some other sites across the world as well. But with this, we've been able to write our clinical trials. And then we are basically hoping that some of these other sites can form our consortium, and then we can just build a stronger network for developing more clinical trials. This is another clinical trial that we just closed actually last week, but essentially we took everything we learned from our first Cyberknife clinical trial, we applied it towards a Gammapod 5-fraction clinical trial. We had special dose constraints, and we tweaked the dose that we wanted to treat, and basically we treated, and we did this in conjunction. University of Maryland was one of the subsites on our study. So hopefully we could, with a little bit more follow-up, we'll be able to publish this study. So where do we go from here? So is there another potential paradigm shift in partial breast radiation? So I think that the future of early breast radiation is to treat in the preoperative setting. So right now, the way that we do it is we do surgery first, and if patients opt to get breast conservation, so they want to save the breast, we then do radiation afterwards, which means that we radiate basically either the entire breast, or we have to radiate the lumpectomy cavity plus a lot of margin. However, what if we did this preoperatively, and we basically are able to target the actual tumor itself, and that way we would be targeting a lot less tissue. And then you have the benefit of actually having the surgeon remove all of the irradiated tissue. And so women don't even have to live with the irradiated tissue in their body anymore. So that's where I think things are moving. There have been a couple of trials that have looked at this. I mean, this is in the very preliminary stages. The other advantage to this is we can actually see if we deliver these high doses of radiation. I think there is a unique opportunity to see if we can actually completely eradicate or completely get rid of all of the tumor with just the radiation alone. So one of the most provocative studies came from the Netherlands, and basically they did one treatment of radiation to the actual tumor, and then they did surgery 6 or 8 months after radiation, and they did this on 32 patients, and follow-up was about 18 months. And what they found was that with kind of this low dose, the 33% and 41% had a near path CR, which basically means a near complete response where the tumor was almost gone. And then when they looked at, and then basically, so I'm sorry, that was for the people that had no more tumor left. And then for the people that had almost like a near complete response, so there was a little bit of tumor left, that was 33 and 35% after 6 and 8 months. And there was low toxicity here. Over basically the last decade, there has just been only a handful of trials that have kind of looked at preoperative radiation in different ways. Duke looked at it, but did surgery 10 days later. So there wasn't really an opportunity to see what tumors were going to shrink. This is the trial, the ablative trial is the trial I just spoke about. The Netherlands also did another trial with a little bit different fractionation. They did 10 treatments or 5 treatments, and their path response, complete response rate, so no more tumor, was only 20% using that. And then the University of Maryland did a regimen where they did the 10 treatments, similar to what like the 3D conformal treatments were, with a path response rate of 15%. So we currently are most excited about our ongoing trial right now that we have with preoperative radiation. We're doing 1 treatment, and we're doing higher doses than what the Netherlands did, because we are trying to see if we can increase the rate of eradicating the tumor before surgery. And this is for early stage breast cancer patients. We are treating these patients on either the Gammapod Cyberknife, or we got another machine called the MR linear accelerator, which actually is an MRI, and then it has a linear accelerator on it. And we just basically unloaded that machine within the last month. So we're very excited, and we'll be treating probably our first patient on that with the preoperative regimen here in the next couple of weeks. This is our current clinical trial. Prior to the radiation, we are obtaining biopsies, and then we're getting biopsies again at 2 weeks after the radiation. And basically, what we're doing for that is I have paired with one of our breast radiation faculty members who has a translational lab, Dr. Aluri, and then he's going to be testing the genetics of the tumor to see if we can predict which tumors actually are eradicated with this radiation. And we're hoping that this will basically give us a lot of information. So as preoperative radiation becomes more common, we can look at genetics of patients' tumors and make some predictive predictions or mammograms on this. And then patients would get the surgery. We're trying to have surgery somewhere around 6 to 8 months, and they would be taking anti-hormone treatments during all of this. So this will kind of like help calm our patients so that they're getting treated with the anti-hormonal treatments. And then we're just essentially watching these tumors shrink over the next several months. The last thing I wanted to talk about here was our cardiac sparing program for left-sided breast cancer. So I showed you initially, when we treat left-sided breast cancer, we have kind of like our tangential beams that are coming right here, but some patients have anatomy where their heart is right up against the chest wall, which is not good because then some of the heart can be in the radiation field. And so we really don't want that. So one of the programs that we've developed and has been very successful is a cardiac sparing program. And we basically have all of our left-sided breast cancer patients take a big deep breath during their radiation treatments. And essentially what that does is it actually changes the shape of the heart. So the heart becomes elongated because the lungs fill up with air. As the lungs fill up with air, the diaphragm moves inferiorly or moves down, and the heart actually moves back and away from the heart, from the chest wall, which you can see here. So when we come in with our tangents, we're actually moving the heart out of the way of the radiation field. Here you can see this is our radiation portal field, and you can see here the tip of the heart is in the radiation field. This is regular free breathing. When the patient takes a big deep breath, it moves back and away from the chest wall, and we're able to spare the heart. So very simple maneuver of having somebody hold their breath for 30 seconds and treating them with a breath hold position, I think is very important. It's something that we institute for all of our left-sided breast cancer patients. And I think this is a vital aspect of left-sided breast cancer radiation therapy treatments for whole breast radiation. We are using they're basically kind of like lasers to monitor this for the patients, and we're able to monitor. These lasers are basically taking these surface pictures of the patient's chest wall, and we're able to monitor to the millimeter if they're in the correct position when they are obtaining these breath hold positions. And this is utilizing technology called Vision RT. So this is called real-time 3D surface rendering is essentially what it is. But basically the point is that we're able to get these breath holds and move the heart out of the way of radiation field for left-sided breast cancer. Okay, so I have spoken a lot. I've put in a lot of information and trying to kind of just give you like a little taste of what the breast radiation program here at UT Southwestern is doing. And so I hope that this has been really useful for everybody. But I want to end off and I want to ask everybody a challenge question. I am going to challenge everybody that has been on this talk. Who are you going to ask tonight or tomorrow? Are you up to date on your mammograms? And I even want you to pull this because I think when we make goals, if you write your goals down, you're going to be a lot more successful at obtaining those goals than if you just say it in your mind. So this will be our way of writing it down is by taking a poll. And 50% of people here are saying that they're going to ask a friend. And so I please, for the sake of Breast Cancer Awareness Month, please live by that and please do that either tonight or tomorrow. And that could save a life. So thank you so much for listening to me talk at a very high speed. This is my email address. If there is anything that I could do to help you or a loved one, please let me know. I'm here to give a helping hand to everybody. And I thank you all so much.
Thank you so much, Dr. Rahimi. We appreciate your insight this evening. I'd like to add one celebratory remark. UT Southwestern is nationally ranked by US News and World Report, placing us among the country's leading cancer treatment facilities. Congratulations to Dr. Rahimi and the entire team at Simmons Comprehensive Cancer Center on this tremendous achievement.
Thank you.
Now for audience questions. And if you have a question and you're watching, you are more than welcome to type that into the chat. But we have quite a few questions that were asked ahead of time. So I'm going to first ask one of those. What, other than a manual exam, should persons with dense breast tissue do? Just wait another year for an X-ray, or anything else you would recommend?
So that's a really great question. So when you get a mammogram, if you have dense breast, that would be on the mammogram report. And so one thing you could do is you could talk to your physician. And in some circumstances, what we do is we do like different screening for patients with dense breast. Sometimes they will incorporate an MRI. So typically the way that works is you would get a mammogram, and then 6 months later you would have an MRI, and then 6 months later you would have a mammogram. So you're kind of like alternating between mammograms and MRIs. Not for everybody, but it's something you can talk to with your physician to see if you would be a candidate for something like that. It's also that's what we also do for high-risk screening for patients that have very strong family history or other risk factors, as we do the MRI and mammogram dual screening.
Thank you. My next question. Oh, actually, before that, do you mind stopping your screen share so we can see everyone's faces?
Oh, sure. Stop share. There we go.
Thanks. Now we can see everyone. My next question. Okay, let's see. There's a lot of these. Someone asks, why do you use radiation therapy for breast cancer when radiation itself causes cancer?
It's a really, really good question. So everything in oncology care is a risk-benefit ratio. So of course, radiation can cause secondary malignancies and it can cause cancer. But we look at what is the benefit of radiation. And the benefit typically is somewhere in the 50 to 60% reduction of a local recurrence. So that 50 to 60% is much more beneficial than the 1 or 2 or 3 or 4% chance of developing a secondary malignancy. And so we would never do something from an oncologic standpoint that would cause more risk than benefit. And it's something that we constantly are always reassessing, is a risk benefit ratio.
Thank you. Our next question I'm going to pull from the chat. I believe it's pronounced Fatima, but I'm not sure, maybe Fatimi, asks, how would you recommend mammograms for BRCA1 children?
Yes, so BRCA1 children, well, first of all, if somebody is BRCA positive, which is a genetic, mutation, and basically, just so the audience knows what that is, it basically predisposes to certain cancers, including breast cancer. Sometimes it can predispose to like prostate cancer for men. And so when people have BRCA, depending on the age, I think that they need to be in a very like high risk clinic. We have high risk clinics here where we monitor those patients, and we typically will start mammograms at like a younger age. And then usually when people are in their adulthood, we do discuss with them bilateral mastectomies because the risk of breast cancer is so high for BRCA positive patients. Of course, you know, we may not want to do that for a child, so they would need to be in a high risk clinic in which they're being like monitored, and they have like specialists at their very close in their circle to make sure that, you know, they're getting the appropriate care that they need.
Thank you. Our next question comes from Carol. Do you recommend that people with bilateral mastectomy and reconstruction be followed by regular imaging?
So not necessarily. So typically for the bilateral mastectomy patients, a lot of times we are able to follow those patients by just clinical exams. And it kind of depends on the way that the mastectomy was done, but a lot of times with mastectomy, there's not very much breast tissue that's left behind. And so when recurrences do happen, you can actually fill them pretty normally on the chest wall. Now, there are certain circumstances, like if obviously you feel a lump or there's like a change, and especially in circumstances when people have reconstruction and they're using like their own tissue to reconstruct. In those circumstances, sometimes we will get mammograms and imaging. So it's not a straightforward question. And that's also something that, you really need to make sure that you're working with your physicians to make sure that you're getting the appropriate follow-up. But typically it's by clinical exam.
Our next question I'm going to pull from the questions submitted ahead of time.
Okay.
Are there supplements, foods, or vitamins you would recommend for women to take to decrease the risk of breast cancer development? And they also said thank you ahead of time.
Oh, well, you're welcome. So I think one of the most important things is a healthy diet. And when I say a healthy diet, the reason I say that is because something that a lot of people don't know is that a high content of fat in your body actually produces estrogen. And the most common breast cancers are estrogen positive breast cancers. So implementing a very healthy diet that is well balanced with fruits, vegetables, meats, you need a little bit of carbs and not overdoing that and not eating over what your daily caloric intake, what a daily healthy caloric intake is. I think that's probably going to be the most important factor in like the diet realm, because we want to really make sure people are at a healthy weight. But there is not like one like superfood, right? I mean, if there was a superfood, we would all be taking it and there would be a big company that had, this is the superfood that you take. I think it's going to be more of kind of like a holistic exercise, just maintaining a healthy body weight, eating your vegetables, having high antioxidants. Antioxidants are really good, which are found in your green leafy, which are found in your fruits, and vitamins, which are going to be in your green leafy vegetables. And then, you need protein also. And if people are vegetarians, then they need to make sure that they're getting protein from appropriate sources to supplement that. But that's what I would advocate. And I don't think that there is like one vitamin or one food that's going to really like help completely reduce the risk. But I think just more kind of an overall approach to that, to health and diet and exercise is going to be the way to go for that.
Thank you. I had a suspicion there was no secret ingredient.
No superfood.
Maybe one day. Our next question comes from Pearl. How are the patients selected for the Gammapod and other trials?
Yeah, so that's a great question. So right now we're treating mostly early stage breast cancer patients. And then part of it, we have a much more comprehensive stereotactic partial breast program. So we have the Ethos machine, which is a machine I didn't talk about, which is a CT scanner machine, but it does adaptive capabilities, which basically means we can image we can image like on the machine, and then we can like change based off of the way that the breast changes shape. We also have the MRI LINAC. So it really depends on where the location of the tumor is and the patient's anatomy as far as which machine we're going to treat them on. And there's pluses and minuses for each machine. And that becomes a very complicated conversation, but essentially each machine has advantages and disadvantages, and every patient's anatomy is going to be different, and the tumor is going to be located in a different setting. And that's where the physician is going to kind of choose which machine and which technique is going to be appropriate for that particular patient. In general, most of our trials have been for early stage breast cancer patients as far as doing these stereotactic approaches, but we do have options for later or patients that don't have early stage breast cancer, and which we can kind of like shorten their treatments a little bit with the boost. So typically we do whole breast radiation, and then the last 4 or 5 treatments is a boost where we're just focusing just on the location of the tumor bed. And we have been treating some patients on the Gammapod and just doing it in one treatment instead of the 4 or 5 treatments. So it essentially shaves off 1 week of treatment for later stage patients. And then the other thing I was going to say is we do have some more clinical trials that we're going to be writing this next year. We have it on the agenda for 2022. So we are going to incorporate some of this other technology for later stage patients as well. But essentially that's kind of how it is. It's typically for the early stage patients, they're 3 centimeters or less, estrogen or progesterone positive, and just in early stage breast cancer patients without any positive lymph nodes.
Speaking of estrogen, what is the current status of hormonal therapy in breast cancer?
So this question I think is particularly asking about hormone replacement therapy. So a lot of women, as they become, just background for the rest of the audience, a lot of women as they become menopausal, their estrogen and progesterone levels start to decrease, and then women will get a lot of symptoms like hot flashes and maybe mood changes. And so many women will opt to get hormone replacement therapy, where they get basically, they take a pill or patches. There's a lot of different ways you can get the hormones, but they basically replace that hormone that the body is not naturally developing anymore. And right now, I think it's still like controversial, like if it does cause breast cancer or not specifically, but in general, from asking a breast cancer specialist, I really don't like it when people are on hormone replacement therapy, just because I see a lot of patients that are on hormone replacement therapy and then end up having a hormone positive breast cancer, which is essentially feeding the tumor. And essentially when people have a hormone positive breast cancer, one of the treatments is we put them on pills that are anti-hormone pills to block those hormones. So we're basically doing exactly the opposite of what hormone replacement therapy is. And I can't tell you every year how many people we take off hormone replacement therapy. So, there are some situations where I think, it can be done, but I think, people just need to be aware of that risk, and they need to work with their physicians pretty closely if they're going to do that, and definitely be getting mammograms and maintaining their breast health if they're going to go down that route.
That's really good to know. Thank you. Mary asks, is it best to get a 3D mammogram?
So 3D mammograms are kind of like a newer type of mammogram. Mammograms have typically been done with 2D methodology. The 3D mammograms are really good for patients that have dense breast. So a lot of younger patients, like earlier in their 40s, will have dense breast. And so for dense breast, it's a really great utility. If somebody doesn't quite have dense breast, then at that point, you should probably talk to a radiologist to see if there's going to be a huge benefit for having a 3D over a 2D mammogram.
Not a question, but Dolores is a registered dietitian, and she said, thank you for your response to the supplement question.
I'm glad she's on the same page as me.
Caroline asks, are these radiation advancements for patients with DCIS? If so, which ones?
Yes, pretty much all of the ones we treat DCIS patients all the time with Gammapod, Cyberknife. We can do it now in the MR Linac. The other machines, we do partial breast radiation for DCIS patients. So that's considered stage 0 breast cancer, so very early stage.
Thank you. Next question from Pam. What would be different from this treatment plan for HER2 positive breast cancer?
Okay, so what HER2 positive is, just again for background information, when patients get diagnosed with breast cancer, we are looking at 3 different receptors on the tumor. Estrogen, progesterone, and another one, which is a growth factor called HER2 mu. And some cancers actually overexpress HER2/mu, and we call those HER2 positive breast cancers. So depending on how big the tumor is, HER2 positive breast cancers usually require chemotherapy, and standard of care is not to do partial breast radiation on those patients. Again, next year, 2022, we're hoping to have some more clinical trials to basically incorporate some of these other subtypes that normally have been excluded from partial breast irradiation. But as of now, standard whole breast radiation, plus or minus like lymph nodes, depending on if lymph nodes are involved, is the type of radiation we would do for a HER2 positive breast cancer.
We have a couple minutes left, but someone says that they have a friend who was recently diagnosed with breast cancer. What steps should they take to enter the treatment? For example, what type of specialist do they schedule with first, and how long does it take to get an appointment in general?
Okay, so first thing I would tell them is if they have not had their imaging at UT Southwestern, get your images on a CD from wherever you got the images from, and then you can call the UT Southwestern Breast Surgical Oncology Clinic. And the breast surgeons usually are kind of the ones that will coordinate the care and get you in. If we need to go straight to surgery, they'll take you straight to surgery. If you need to see a medical oncologist and a radiation oncologist, they will send all of the referrals, and they will kind of be like the gateway. But please come, if you can, come with your images on a CD, and then basically bring it to your appointment with a breast surgical oncologist. And you can get that by Googling UT Southwestern Breast Surgical Oncology, and then the phone number should come up. And we have pretty quick turnaround time here, especially if we know it's a new diagnosis for breast cancer.
Thank you. That's really helpful information.
Yeah, and if you guys are interested in the preoperative radiation, I'm always happy to see people like right away as well. Even if we can't get into the breast surgical oncologist, I can kind of help arrange that. But typically the surgical oncologist is going to be like the gateway person to kind of help out with everything.
Thank you. My last question, what is dense breast tissue?
So dense breast tissue is essentially what it sounds like. I mean, if you have some breasts have more fat, it's more fatty replaced. And then other breasts have more breast tissue rather than fat. Usually the breast is just made out of fat anyways, but there's usually like more or less fat content. And so when you have more breast content rather than fat content, it can kind of sometimes obscure the mammogram, versus if somebody has more fat in the breast, the mammograms are very highly, but usually it's a lot easier to see all the tissue on a mammogram. So that's what we're basically talking about when we say like dense breast tissue. Typically women that are younger are going to have more dense breast tissue. And then as you know, we get more towards menopausal age and we have all the hormone changes, it becomes more fatty replaced. All women have fat in their breasts though.
Okay, I lied. I have just one last question.
Okay, one last question.
Into this profession?
I'm sorry, say that one more time.
What prompted you to get into radiation oncology?
So we had to end off on that question, right? So I actually lost my mother to breast cancer at the age of 14. And she was diagnosed when I was probably 11 and my sister was 8. So I saw it firsthand and experienced it firsthand. And so at that point, you know, I knew that was going to be my mission and that was what I promised her. And so that's what I'm going to do for the rest of my life.
Thank you, Dr. Rahimi. It was fascinating to learn about developing treatment options and all of the new technology developments in breast irradiation. Thank you to Joya and Jenny for helping run tonight's events. And thanks as well to our colleagues at Simmons Comprehensive Cancer Center and in the Radiation Oncology Department. We hope you all will join us in 2 weeks on Thursday, November 4th for our next Science Cafe episode on obesity, diabetes, and genetics with Dr. Reina Gupta. Check out the chat for the registration link, and we'll also be emailing you the details soon. After that, will be a program on the science of aging on November 18th, and our final program of the year on December 2nd, focused on mental health issues and the pandemic, especially with seasonal depression that can occur during the holidays. Before we adjourn, we must implore you and your family and friends to get a COVID vaccine. Vaccines protect you from severe illness and death from COVID-19 and its variants. For more COVID information, including vaccine appointments, click on the yellow COVID info bar at utswmed.org. Finally, even if you are fully vaccinated, please continue to wear your mask, social distance, and be vigilant with hand hygiene. Thank you for doing your part to contribute to our collective public health. And for now, we wish you all good health, good spirits, and a good rest of your evening. We are adjourned.